Good morning. We have a wonderful topic for our grand rounds today by a distinguished visiting lecturer. And this is a distinguished visiting lecturer that I happen to know from my days in California. Dr. Francis Liu was a very well-respected and prominent senior member of the Department of Psychiatry at the University of California, San Francisco, when I was there as a junior and mid-level faculty member. And he had a lasting influence in terms of the department's awareness of and involvement in clinical activities and educational projects focused on really being aware of the diverse needs of the populations that we were serving in San Francisco, and also by extension of diversity kind of within the department and in the medical school. Dr. Liu is currently the Luke and Grace Kim Professor in Cultural Psychiatry, Emeritus at the University of California, Davis, the only such chair, as I understand it, in the country that is focused on cultural psychiatry. He's also a Distinguished Life Fellow of the American Psychiatric Association, and he has, as I've sort of implied to you, just been a key force in terms of cultural psychiatry, cultural competence, psychiatric education, particularly around mentoring and career development, psychiatry, religion, and spirituality, and he has taken that particular interest and married it with a kind of, I think, what I would describe as a long-standing passion he has for film and psychiatry, and has done many interesting presentations on film and psychiatry and themes, transcendental themes, and so on at very prestigious institutes such as the Esalen Institute. He has presented at every single APA annual meeting since 1984, which I think gets its own kind of medal, and since 1993 has been a member of the Group for the Advancement of Psychiatry, Cultural Psychiatry Committee. In 2008, the American Psychiatric Foundation awarded him one of its Advancing Minority Mental Health Awards, and the Association for Academic Psychiatry has awarded him its Lifetime Achievement Award. He currently serves as the board of directors of the Society for the Study of Psychiatry and Culture, and is a past board member of the World Association of Cultural Psychiatry. And in 2016 APA annual meeting, President Renee Binder presented him with a special presidential commendation for extraordinary leadership and outstanding contributions to the field of cultural psychiatry. And as I've mentioned, he's been more recent, well, actually this goes back a couple of decades, but he's really been continuously and actively involved in co-leading or presenting film seminars, which bring together an audience watching a series of curated films and then thinking about themes and again, sort of spiritual and artistic marrying of concepts that are shown throughout the films. So you can see we have indeed a distinguished visiting lecturer today who will be presenting to us on the DSM-5 outline for cultural formulation and the cultural formulation interview, which is something that everyone involved in clinical work should be aware of, and start informing us about tools for culturally competent care. Thank you, Francis.
So thank you very much, Dr. Vinogradov, for that kind introduction and your invitation and that of Kaz Nelson to come and present to you today on these two tools that I hope you can implement in your clinical work involving assessment, differential diagnosis, and treatment planning, something you do every day with patients, that you can bring it into your work. In other words, adding the cultural lens to what you're already doing to make a more accurate, more complete diagnosis, and also to help optimize your treatment planning. So I have no disclosures, and this is my email address and website if you want to reach me. Feel free to do so. And also, if anybody wishes a copy of these slides, you can contact Barney Franks, who will make them available to you. I'm free to happy to have them distributed for your review. This is the outline of my talk. I'm just going to spend a few minutes here so we're all on the same page about what we mean by cultural competence. I'm going to give you my take on it in just a few slides, and then to present two important rationales, quality of care, how do we improve it, and also how this ties into our ACGME standards for psychiatry residency training programs. I'll point out four competencies that I think relate very much to what I'll be talking about today. And then going over the cultural issues in DSM-5, starting with a quick roadmap, our two clinical tools, and the supplementary modules of the cultural formulation interview, and highlighting changes from DSM-4 to DSM-5. Just curious, how many people here in the room have heard about the outline for cultural formulation, or the CFI? Can I show a raise of hands? Okay, so maybe about a third in the room. And as I visit departments of psychiatry, spreading the good news about cultural issues in DSM-5, this is what I often see, is that we have things to learn about in DSM-5. So I like this definition very much of cultural competence from the Joint Commission Accreditation of Healthcare Organizations, of the ability of healthcare providers and healthcare organizations to understand and respond effectively to the cultural and language needs brought by the patient to the healthcare encounter. Every word here counts. Competence, yes, competence is important because it's an ability of both individual providers, clinicians in the field, like yourselves, and healthcare organizations, be it the Department of Psychiatry or the medical school or the medical center. So that speaks to systems cultural competence, clinical cultural competence, systems cultural competence, to understand and respond. So that's two very important things. There's the understanding, but then how are you going to respond to, how's things going to be adjusted here? Respond to the culture and language needs, so it's culture and language, communication, not only people with limited English proficiency, but also those with limited sight and limited vision or limited health literacy. These are all aspects of communication and language, if you will. Needs, so we have needs here, brought by the patient to the healthcare encounter. So this is very real. It's happening every day. Okay? It's happening every day. On one page here is kind of my deeper dive into this in terms from the individual cultural competence aspect of what do we mean by this. And I see cultural competence as kind of an umbrella term that encompasses all of these elements. I see that as the most comprehensive term. So it's a journey. It's not just an endpoint. Listening to my lecture here today will get you so far, but it's an ongoing, continuous learning process. And it has to start with yourself, understanding your own cultural identity, values, prejudices, and biases that we all may have. And then secondly is humility, the attitude of humility about the limits of your assessment and treatment knowledge and skills. And to condense that into a motto to take away with you here today is ask, don't assume. Ask, don't assume. Okay? Then there's the valuing of diversity, an appreciation of cultural differences and how that might play a role in our care. And then ensuring safety, meaning being aware of the power dynamics that result from cultural differences that add on to, for example, doctor-patient relationship or supervisor-resident relationship. There's an inherent power differential, and cultural differences may exacerbate that power differential, and that we need to be aware of and not inadvertently add to it that would be counterproductive. And then finally, responsiveness to cultural differences via adaptation of our assessment and treatment. That, again, is the bottom line that we need to keep in mind. We're not just going through an exercise for intellectual interest here, but we need to apply it to our work. So now I'm just going to quickly go over some landmark reports that I know are quite ancient by now, but I think really provide a bedrock for why we are interested in this. And so the Institute of Medicine, now the National Academy of Medicine in 2001, issued this landmark report indicating that we must improve our healthcare system. And they enunciated 6 quality outcomes as goals. And I just wanted to point out 2. One is patient-centered care, providing care that is respectful of and responsive to. You see that again? Respectful of, understanding, and responsive to individual patient preferences, needs, and values. And so that ties in with this culturally and linguistically competent care. And finally, equitable care, providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, socioeconomic status, and there's more. And this ties in with eliminating or reducing healthcare disparities or mental health care disparities, or this whole drive towards health equity, which I think is an important, health policy driver. So the second follow-up report from that one focused on the role of race and ethnicity. And this landmark report documented for the first time that there were racial ethnic minorities receiving lower quality of health care, controlling for all of these variables. And why? They pointed out to a whole series of systems cultural competence issues, and then also clinical encounter factors contributing to these disparities. And I just want to take a moment, a little diversion here, to just point out a very important report. In 2001, the Office of Minority Health in the Department of Health and Human Services issued the CLAS standards, CLAS, standing for Culturally and Linguistic Appropriate Standards. And in 2013, these were revised and updated. I was part of that task force that did that. And just this year, a learning module, training module, was put on a website that helps discuss systems cultural competence issues for behavioral health providers. And so the website to go to learn about CLAS and also this learning module is thinkculturalhealth, one word, .hhs.gov. thinkculturalhealth.hhs.gov. So as I said, systems cultural competence issues and then clinical ones. And as you can see here, the report talked about biases and prejudices, stereotyping, and clinical uncertainty as all factors from the clinician that might cause these healthcare disparities. Now, of course, we also now need to think about the biases and prejudices of patients that might also impact this as well. And when we speak about biases, taking a deeper dive at what we mean by that, broadly speaking, we can think about the intended, conscious, and explicit biases, but also the unintended, the unconscious, or the implicit bias. And there has been a lot of discussion and writing about this concept of implicit bias. If you can just Google implicit bias Harvard, you'll come to the implicit bias test that you can take online, and that's often very revealing to help you understand this whole concept of bias. And of course, there are many different cultural identity variables that we could see biases emerging. And this could be related to personal experiences, personal development, but even our professional training. For example, as we all know, homosexuality was a mental disorder until 1973, and the bias against religion and spirituality was very prevalent in psychiatry and psychology until the early 90s, that it was felt to be not within the realm of psychiatry or psychology or was some form of psychopathology. As we know, Freud called religion an obsessional neurosis. And then only in the early 90s did that begin to change. And I think psychiatry and psychology is more embracing of religious and spiritual beliefs to see and to look more carefully at it. Now, another very important landmark report was Mental Health, Culture, Race, and Ethnicity from the Office of the Surgeon General, for the first time documenting for racial and ethnic minorities poor quality of mental health care. And I remember very vividly on September 8, 2001, David Satcher came to the APA September components meeting and gave a 45-minute plenary session where he talked about his report. And President Richard Harding of the APA immediately afterwards got up and said that he was going to appoint a task force to create a strategic plan to how was APA going to make a difference here. And he eventually appointed Pedro Ruiz and Alpha Stewart. Pedro was president of APA around 2009, 2007. Alpha Stewart was just our past president. Ed Folks, who was a cultural psychiatrist, and myself. And we created a plan, and which I'm happy to say has resulted in a number of initiatives. One of them being this presidential project of Pedro Ruiz with Anel Prim, Deputy Medical Director of APA at the time, which is kind of a follow-up report to the Surgeon General's report that I really still highly recommend, even though it's 10 years old, looking at disparities in psychiatric care related not only to racial ethnic minorities, but also to other cultural identity variables, clinical conditions, and services. Now, moving on to the ACGME standards, I just want to mention 4 here. Again, these are standards from the Accreditation Council of Graduate Medical Education, accrediting the training programs of all specialty residencies and fellowships. So for the specific ones around psychiatry residency training, there are 6 core competencies. And so again, I'm just going to touch on 4 here. One was patient care. We have that, as you can see, residents must demonstrate competence in the evaluation treatment of patients from diverse backgrounds. Again, broadly speaking, a number of cultural identity variables listed here. Then a deeper dive into that, I think, is this one of demonstrating competence in forging a therapeutic alliance with patients and families, again, from all of these different diverse backgrounds. And yet, another deeper dive into therapeutic alliance, that concept of therapeutic alliance. And again, that's something that we think about every day. You know, what kind of treatment alliance do we have? What kind of rapport do we have with the patient? And so here, under medical knowledge, you can see residents must demonstrate competence, knowledge of American culture and subcultures, including immigrant populations that you have here in Minneapolis, particularly those found in the patient community associated with the educational program. So the Somali and the Hmong populations here, I think, are very pertinent, with a specific focus on the cultural elements of the relationship between the resident and the patient. Now, keep this in mind, because we will see this in Part D of the outline for cultural formulation, including the dynamics of differences in cultural identity, value, preferences, and power. Okay? And I think this concept of cultural elements of the relationship also pertains to resident-supervisor relationships. You see what I'm saying? And this can go, again, this is can go both ways in terms of how the resident affects the patient, but how the patient affects the resident. And I'll give some examples when I come to that section. And the last standard, or the last competency here, is under professionalism. Residents are expected to demonstrate sensitivity and responsiveness to a diverse patient population, again, broadly speaking, including these cultural identity variables. Now, moving on to the roadmap, where does culture appear in DSM-5? In the Section 1, the introduction to DSM-5, we have a few pages on cultural issues and gender differences. And then in Section 2, which is the bulk of DSM-5, in the narratives of certain diagnostic categories, we have culture-related diagnostic issues. And in the index, there is a listing of where this appears in DSM-5. And then also we have gender-related diagnostic issues, and I'll show you an example of this in a moment. And then some of the diagnostic criteria were changed, and I'll show you an example of that. And then I also wanted to touch on a section of DSM-5 known as other conditions that may be a focus of clinical attention, but are not mental disorders. And there were two conditions I wanted to bring to your attention. Then in Section 3, there is a section entitled Cultural Formulation, and here we have our two clinical tools. And in the appendix, there is a glossary of cultural concepts of distress, replacing the glossary of culture-bound syndromes, and that's a term that no longer exists in DSM-5. And I'll discuss this in a moment as well. So in the introduction section, these are just some concepts that are brought up here. And the big picture here is our understanding of culture and cultural identity of a person. The big picture here is moving from a singular category like race or ethnicity, like Chinese or, Latino, moving from just one categorical category, to understanding that cultural identity, culture, involves a whole range of experiences, as you can see here, in a number of things. And that furthermore, we need to think about cultural identity as not static, like you're born X and that's your cultural identity and that's the way it's going to be forever and ever, but rather dynamic. It can change over time. It can change over place. Someone who's born in Vietnam and is Vietnamese and lives there their whole life. They have a cultural identity. But that Vietnamese person, should they come to the United States, and also it depends on what age and also under what condition. Are you a refugee boat person? Coming here, they change over place, over time, and how does that cultural identity change, okay? And then the third concept here is the concept of intersectionality. Again, moving from a singular category fixed in time to a dynamic one related to intersectionality. What do I mean by that? I'm talking about thinking about race and ethnicity, gender, age, socioeconomic status, religion and spirituality, sexual orientation, geographic location, political orientation. I think that's an important one these days, and even regional differences between California and Minnesota, for example. So you put all of these together and the intersectionality, we come to trying to understand the highly individualized cultural identity of the person relating to person-centered care. Here's an example of culture-related diagnostic issues. This actually existed in the DSM-4, pointing out that especially when there are differences in the cultural identity of the clinician and the patient, we need to understand that ideas that appear delusional in one culture may be commonly held in another, and that in some cultures, visual or auditory hallucinations with a religious content, such as hearing God's voice, are a normal part of religious experience. So this section asks the question, challenges the clinician to ask questions. So, example, patient says, I hear a voice. Okay, well, our typical way of thinking about that is voice equals auditory hallucination equals psychotic symptom equals psychotic disorder or mood disorder with psychotic features, especially if there are other associated symptoms, and that means, antipsychotic medication. And we are trained to go down that track, kind of automatically. And so what this section and what this says is, well, before you do that, just ask, just think, just stop. Is there anything related to the person's culture where this voice might be part of their normal experience? What's psychopathology, what's cultural? Just ask that question, okay? Now, what this is pointing out is that sometimes an error can be made. You can make a rapid assessment. This is psychopathology. But the other error that you could make is if you don't know about the person's culture, you can just say, that person is, from this Christian denomination, and of course they hear voices. And so this is simply part of the person's culture. Without making a full assessment, you kind of prematurely make that decision. And that could also be an error. And so you have to go through an assessment process. And because sometimes it could be both. In other words, maybe in that person's culture, they do hear the voice of God as part of their religious experience. But in this particular case, they're hearing a voice to tell them to jump off the bridge. And that, we would say, is psychopathology. So careful assessment is needed. And then here's an example of, in panic disorder, we have this discussion of diagnostic issues, but in terms of diagnostic criteria, this was added, work of Devin Hinton, looking at certain symptoms should not be counted as part of the panic disorder criteria. Now, moving on to the V Codes section, again, these are not mental disorders, but distressing experiences that bring patients to the clinicians. And I would dare say that many of our patients actually are experiencing these problems, as you can see. And I wanted to bring up two in particular. Religious or spiritual problem, which first was entered into DSM-4. Robert Turner, David Lukoff, and myself wrote a proposal to the DSM-4 task force, and it was accepted. And these, again, are distressing experiences that involve a loss or questioning of faith, problems associated with conversion to a new faith, or questioning of other spiritual values. So, for example, someone has a mystical experience or a near-death experience, and their sense of reality, of everyday reality, is a little disturbed, and they're distressed. So, and they come to you. Am I going crazy? You know, do I have psychopathological symptoms? And someone goes on a meditation retreat that's silent for a month, and again, they're distressed about it in some way, anxiety or whatever. Again, the same question. And this provides you a category. Patient comes in and says, I've lost my faith in God. God is punishing me for my sins. How many people have had patients like that or have heard of patients like that? Great. So again, about a third of the room. So this happens. And this category permits you to make a diagnosis, to say these are religious or spiritual problems. They're not psychopathological per se. Now, they can be part of your diagnosis. The patient may fulfill all the criteria for major depression and have this as well. Now, why do you go to the trouble of all of this? Because the V codes are not billable. They're not disorders, mental disorders. So why even care about them? And that probably happens in our day-to-day work just because of all the things we have to think about. The reason why I bring this up is because for some patients, it might be very important to make the diagnosis, put it on the radar screen so that you can attend to it in your assessment and treatment plan. So if you don't understand, the meaning of God is punishing me for my sins, so on and so forth, or the stress the patient has, then you may then want to get a spiritual or religious consultation, and they might recommend certain religious or spiritual interventions, such as prayer, that they would be skilled and knowledgeable about providing. We may not be skilled or knowledgeable about providing that, and that would be quite understandable. That may be part of the holistic care of the patient. Just imagine if the patient felt heard and respected, and we respond to their needs, they may then take our medications, even though that may not be their primary explanatory model for their distress. Do you see what I'm saying? This is a way of bringing together different aspects of responding to patient's distress. And here is another V code that I think would be very pertinent to immigrants and refugees that you see, so that this is part of the diagnosis and that we then attend to this in the treatment plan, be it English classes or vocational training or psychoeducation or, supportive services, but that's part of the treatment plan. Okay, now moving on to the outline. It first appeared in the DSM-4 as Appendix 9, so hardly anybody knew about it. And that's what's in white. What's in yellow is in the DSM-5. And so it was retained in the DSM-5 with changes. And so there are 5 parts. The first 4 are fields of information that are related, and the 5th part is the summary. So it asks us, clinicians, to understand the cultural identity of the individual, the cultural concepts of distress, the cultural stressors and supports, the cultural features of the relationship between the individual and clinician. So you can see this, how this ties in directly to that ACGME accreditation standard. And then the overall cultural assessment, meaning how does this impact on your differential diagnosis and your treatment plan. Now, the task force on cultural issues, or the work group on cultural issues for DSM-4, headed by Roberto Luis Fernandez at Columbia, and I was part of that 30-person work group, decided that we needed to add something to DSM-5 to help the clinicians ask the questions to get the information for the outline for cultural formulation. So we came up with the cultural formulation interview, 16 questions. There's a patient version and an informant version. And then when you Google supplementary modules DSM-5, you'll come to a PDF with 12 supplementary modules. These are additional lists of questions for deeper dives to understand the different aspects of the outline for cultural formulation. That's all here. But I just want to and then these last four, I think, are very important for patient groups that you are seeing. Children and adolescents, older adults, religion, spirituality issues, and immigrants and refugees. And these are additional questions for you to ask to get more information on them. Now, this is what it looks like, the CFI in the DSM-5. As you can see, it's not just a list of the 16 questions, but there's a guide to the interviewer and instructions to the interviewer here. You see that? And now I'm just going to go over the 16 questions and show you how they relate to the outline for cultural formulation, because they're not in the exact order. Now, why is that? Well, we felt that if you started the interview with, tell me about what's most important in your background or identity, that would be a very hard question to ask right at the beginning. You know, you hardly know the patient. That might be off-putting to patients. So we felt we had to start with the question that you normally would ask, which is, what brings you here today? See? Now, hopefully, you're asking that question right now. You see, so you have one of the 16 already, okay? So that's where we start here, is what brings you here today? And then there's this question about your social network, and how would you describe your problem to them? Now, problem here is caps and in brackets, because we'd like you to use the patient's words. So, wind illness. Well, how would you describe your wind illness to them? And what troubles you most about your problem? Then we have causes or explanatory model. Why do you think this is happening to you? What do you think are the causes of your problem? And how about your social network? What do they say about your problem? So these first 5 questions all relate to Part B, the cultural concepts of distress. And these are quotes from the Section 3 where this is all described. As you can see, it's how these cultural concepts affect the individual's experiencing, understanding, and communication of these symptoms. And there are 3 subtypes, cultural syndromes, idioms of distress, and explanatory models. And then the importance of comparing the patient's experiences and how that relates to the norms of the individual cultural reference groups. And finally, coping and help-seeking patterns. Now, this part applies to questions 11 through 15, and we'll come back to that in a moment. Now, what are these cultural concepts of distress? So, in the glossary, in the appendix here, there are 9 examples, and there are more than 9, but those are the 9 examples. And here you can see the names of the 9 here, and Also, you can see that some of these are syndromes, explanatory models, and idioms of distress. And some of these are related. So, for example, nervios is an idiom of distress, and it is a prominent feature of ataque de nervios, which is a cultural syndrome. So I see the idioms of distress as like the built as the bricks, and the cultural syndromes as a clustering of the bricks, if you will. Okay? And then we have the regions where we see this occurring, and of course we are interested in this because we have patients from all over the world that come here. So I do recommend this book if you're not already familiar with it. Anne Fadiman, The Spirit Catches You and You Fall Down. And this is about a Hmong child who had grand mal seizures treated by a neurologist in Merced. It's a true life story. And the Hmong interpreted this as a shamanic opening, not as a biomedical disorder as the neurologist did. But they never had a discussion about it. They never came to a consensus treatment plan, and it led to the patients not taking the medication and a prolonged grand mal seizure. A child went into a vegetative state for 20 years and then died like 3 or 4 years ago. And that's what we're trying to avoid in our work by anticipating, understanding these things, and working towards a consensus treatment plan. The next two questions relate to the stressors and supports in the person's life. And so this relates to part C of the outline. The 3 key words to remember are religion and spirituality, family, and other social networks. That was added in DSM-5. And Pamela Hayes, in a book that I will reference in a moment, has a whole chapter on this. And again, the concept is, again, we're always interested in strengths and supports, how we're going to help our patients, what would be supportive of the patient. So again, putting on the cultural lens hopefully will enlarge your radar screen so that you may see things that might be helpful for this particular patient. So you can just get a gestalt sense of that as you look at this. These are personal strengths and interpersonal strengths like extended families, religious communities, and environmental conditions. So caring for animals, we know how important that is for some of our patients, and so on. So looking at family, who's in the family, not only the nuclear family, but also the extended family. And a book that I highly recommend, like Ethnicity and Family Therapy, which has 50 chapters, not only on Vietnamese families and Japanese families, but also Irish families and Italian families and Russian families. In terms of stressors, we can think of intrapsychic, cultural identity conflict issues. Acculturation is a very important one. How much am I Vietnamese? How much am I an American? If I was a Vietnamese person born in America. Sexual orientation conflict, which we know in adolescence, having that can lead to suicide or higher rates of suicide. There can be interpersonal stressors where you have cultural identity differences with different values. So a Vietnamese parents, limited English proficiency, very traditionally acculturated, and they have parenting styles of the traditional Vietnamese. And you have the fast assimilating adolescent or young adults who, speak limited Vietnamese and have their own values of emotional expression and so on, and so there are different cultural identities here, and there can be stresses between these that could cause conflicts. And then also to keep in mind, as I mentioned, these other conditions of clinical attention and the social determinants of mental health. So moving on to question 8, this is where we talk about for you, what are the most important aspects of your background and identity? And we have these follow-up questions related to that. This then ties in with Part A. This is what was in DSM-4. And what was added in DSM-5 that's most important here is, again, a broadening explicitly of what we mean by cultural identity, including religious affiliation, socioeconomic background, personal and family places of birth and growing up, migrant status, sexual orientation. But there's more: gender, age, political orientation, all can be important here. But the idea is to expand that, the intersectionality I brought up earlier. So Pamela Hayes, in her book, Addressing Cultural Complexities in Practice, uses the word addressing as an acronym. You see addressing and you see addressing here. And these are the cultural identity variables, you know, what I brought up earlier, how they all intersect with each other. And language is over here because there's no L in addressing, and yet that's a very important part of it. And so again, ask, don't assume. You know, Asian, well, there are different subgroups of Asian, and even national origin doesn't define a homogeneous ethnic group. For example, there are 54 distinct ethnic groups in Vietnam. And so, moving on to questions 11 to 15, this has to do with self-coping and the treatment pathway. And the last two questions of this set are the key questions, okay? But here is, again, how do you cope with the problem? How does your social network cope with the problem? What are the barriers to care? And there can be many that are culturally related. And then these are the two key questions of what kinds of help do you think would be most useful to you at this time? And what does your social network say would be helpful for you now? Those are the most important questions in terms of how do we then hear that and bring that into our treatment planning. So again, this gets back to that part in the outline, Part B, where they say coping and help-seeking patterns. And yes, I just wanted to emphasize here it's not only professional care, but also traditional, alternative, and complementary sources of care. And we know the primary care, they may come to primary care first or seek a religious or spiritual healer before they come to us. And we need to just understand that this could be part of their treatment pathway. And of course, there are many different approaches that we need to be aware of. Now, moving to the last question is this question, which just touches on the whole issue of differences between the clinician and the patient, and how do we take that into consideration in our care. So this touches on this critical part, Part D. Again, what's yellow was added. Identify differences in culture and language and social status between the individual and clinician that may cause difficulties in communication and influence diagnosis and treatment. Experiences of racism and discrimination in the larger society may impede establishing trust and safety in the clinical diagnostic encounter. And effects may include problems eliciting symptoms, misunderstanding symptoms, and difficulty with the therapeutic relationship. You see how that all comes back? If you don't think about this, there can be problems, basically. So how do you implement this? Okay, so the first thing is to understand your own cultural identity. You've got to start with yourself. And then secondly is comparing the cultural identity of the patient and that of the clinician. So what I suggest is you list down all the cultural identity variables of the patient along the lines I've described, and then of yourself, and you look at the similarities and differences. So let me give you some just concrete examples very quickly. I'm Chinese, I speak only English. A patient comes up to me who's Chinese and only speaks Cantonese. So we have a language difference. Okay, well, obviously, there's going to be a problem in communication, and that's going to affect diagnosis and treatment. So, of course, I need to call a trained interpreter or transfer the care to a person who speaks Cantonese. Okay, I'm a man, patient's a woman. Patient seems very reluctant to give me any history, and at the end of the interview says, well, I'd be more comfortable speaking to a woman. So what do we make of that? Do we just say, oh, treatment-resistant patient doesn't seem to want to give me information, blah, blah, blah? Or do we just think about, we would ask, well, can you tell me more about that? Hopefully you would ask, and you may find out that, patient has a sexual trauma history. We just feel more comfortable talking to a woman. I'm a liberal Democrat, and a patient comes in wearing a Make America Great t-shirt. Well, we have a difference in political orientation. And then the patient says, well, what country are you from? Well, you're off to the races. What do you do with that? How do you deal with that? How do I deal with my countertransference about working with this patient? One last example is I'm an atheist. The patient is a religiously committed patient, goes to church every week for 40 years, and reads the Bible and so on. And you say, what brings you in here today? And patient is God is punishing me for my sins. Well, as an atheist, I don't believe in God. So what do I do with that? How do I deal with this? Do I simply say, well, I'm an atheist, I don't believe in God, and what does religion have to do with psychiatry? So I'm just going to completely ignore this. Tell me about your sleep, tell me about your appetite and all of those other things. And the patient feels disrespected, not heard. You didn't go back to that, and the patient just drops out of treatment. You see, so those are cultural differences that can impact the therapeutic relationship. And I've just given you some very obvious examples. Because we do need to see how these cultural differences affect all of the aspects of the therapeutic relationship that we normally think about. All of these things can have an impact. And there's a whole discussion about transference and countertransference issues also. And again, the biases and so on, both of the clinician and also of the patient, and how that affects us. And then another way of thinking about this section, again, at a very practical level, is what would help the clinician to provide optimal care for this patient. And there are two approaches to this. One are cultural identity matches. Sometimes that makes a difference. So in that first case, the patient speaks Cantonese, I only speak English. Well, I would say, everything being given, a Cantonese-speaking provider would do a better job than me. You see? So that's a cultural identity match. Or the patient wants a woman psychiatrist. Well, maybe that would be the best thing here. Okay? So that's an example of cultural identity matches that might meet the patient's needs and might provide better care. In other cases, that's not so much the issue, and then it's your knowledge and skills around working with these issues becomes more important. Okay, the last part here is the differential diagnosis and the treatment plan. So, what we're trying to avoid here is a misdiagnosis leading to mistreatment, and these are the pitfalls here by not paying attention to the cultural issues. Misunderstanding cultural idioms of distress or explanatory models, either by saying, patient says nervios, and we have no idea what that means. Patient feels disrespected, not heard, not responded to. There can be all these things, not being aware of that. Inadequate relationship to gather history. I think this is so important. This was exemplified in that man-woman example. And then our biased and stereotyping and so on that could impact here. So, and then And then this is an example of, from this resource document from the APA, about paying attention to cultural, religious, spiritual, and personal ideals, bringing that into the treatment planning. And then in terms of the treatment planning, there are two aspects. One is the process of negotiating and managing a treatment plan to maximize adherence and compliance. Now, of course, that is what we are doing every day. You know, we're always worried about patients dropping out of treatment, not taking our medications. This is par for the course. So all I'm asking is that as you're asking those questions, you know, is to put on that cultural lens. Is there something about cultural issues or my relationship to the patient that may be affecting treatment planning? And then content issues. And so for biological aspects of treatment, the whole area of pharmacodynamics and pharmacokinetics, which can be related to race and ethnicity, but also age and gender, that can affect, for example, a certain percentage of Asian Americans are slow metabolizers, and so that's important to think about as you're working with patients. But it does not mean that all Asians are slow metabolizers. You see, that's the thing. And also how other factors can impact on the medications. And then in terms of medication adherence and compliance strategies, how to reframe medications in a way that patients might be more receptive to. So a patient with a very strong belief in God and wondering whether taking the medications might impact on my relationship with God. I heard in one case recently the strategy or the way that was framed was, well, 7.5 milligrams of olanzapine is very small compared to God, and so we think that this will help you, something along those lines. And then combining medications and other biological approaches such as acupuncture, when might that be helpful? And then in terms of psychotherapy, I think to start with respecting patient and family expectations. One of my colleagues from Asian Mental Health, who passed away in 2003, said, be the tiger balm oil at the first interview for the traditionally acculturated Chinese patients. In other words, they expect some kind of relief in the first interview. And if you don't meet it, they don't say this, of course, but if they don't meet that expectation, then the patients will conclude you're not a very helpful doctor and drop out of treatment, leading to disparities in care. So, concrete example is the patient doesn't sleep well as part of the constellation of symptoms. So you may want to make sure that you address that symptom, in the first interview. Then, in terms of the various forms of therapy, for some patients that are family-oriented, family assessment may be critically important. And then how can our treatments be modified? There are now books on culturally competent CBT. How do you infuse cultural issues into CBT? And again, the question of what therapist characteristics would facilitate and hinder treatment. I think that's a very practical question here. And in terms of social cultural issues, remember family, spiritual, religious beliefs, and social networks. In terms of future resources for your future education, I wanted to recommend 3 API books that came out in 2015. The Clinical Manual of Cultural Psychiatry, 2nd edition. It's all about the outline. And then there's the handbook on the cultural formulation interview, both of these with video vignettes. And then the Social Determinants of Mental Health that has 10 chapters on the evidence for how these are social determinants in mental health. And so, again, I think many of our patients are facing these problems, and they kind of just become background issues. But how about bringing them to the foreground so that we understand these ideological forces that are impacting on our patients? How do we then diagnose them as V codes? So we put them on the diagnosis. And then how do we address them? And this is the whole concept of structural competency that has been written about. Helena Hansen, Jonathan Metzl, this concept of structural competency to address these social determinants of mental health. So we have these, and then we have these. And I think this is the last slide. Another resource is the Society for the Study of Psychiatry and Culture. We'll be having our 41st annual meeting in Providence next year. There's a Transcultural Psychiatry Journal as part of the membership. There are webinars. There's a library of about 15 webinars now that are just wonderful. And you can learn more about that at psychiatryandculture.org. So thank you very much for your attention. Yeah. So I think we have a few minutes for questions, comments. Again, I know I've thrown a lot of PowerPoints at you here, so please email Daniel Franks for the slides. Yeah.
I've been throwing dilemmas at you all evening and all morning too, but I've got another dilemma for the sake of kind of illustrating some of the concepts that you discussed this morning. Thank you so much for an outstanding talk. It's a privilege to have you here. So we'll do seminars on having difficult conversations with patients. I'm always impressed with the medical students who bring up dilemmas, and I try to coach them, but I think your coaching would be a little bit better. So one of the difficult conversations they're encountering is when a patient comes to them and says something like, I would prefer I'm having urogynecologic surgery. I prefer everyone on the team be female for cultural preferences. That's my cultural preference. And the clinician will think in their mind, well, we could find a tech over here that's a woman and a tech over here, but this team works together. We have excellent outcomes because of our excellent training together. You know, we've been working together a long time. We have very good outcomes. And they're wondering, can you say, well, we could accommodate that, but your outcome might not be as good because we have worked together a lot more. You know, like how would you approach that request when you feel that it's a good request, but there's a quality issue then in this particular context?
Yes, thank you very much for that question. I think everything starts with respect, and I know this is difficult because we're all so busy. You know, this is easier said than done, but it has to start with respect. It has to start with the patient feeling heard. I see this as of concern of yours. Can you tell me more? You know, so respect and empathy, and then trying to understand more and empathizing with that, and then making some assessment as you're hearing that, and also thinking about, well, what are the resources that are possible here, and then to make a judgment about to what extent that can be provided or not, and if it can, and if it, if your conclusion is that we work as a team together, and then I would just simply explain that. Again, if that seems to be feasible for that patient's particular concern. Yeah.
In a shared decision-making way, kind of say, here's the risks and benefits of
yes. So you're
particular.
kind of bringing the patient into that decision-making process by just asking more and having the patient feel feels at least heard. I think that goes a long way. Yeah.
Thank you.
Thank you. Thank you for your talk. Just to piggyback on that, and this is not my question, but what about when they say, I only want to see Americans, or I don't want to work with that person, they're not Christian or something?
Right. Right. So this gets to what I talked about, is that sometimes patients can have biases or prejudices or simply preferences, like what you're saying. And again, I would take the same course of action, is to say I see this as of great concern to you, and can you tell me more? So again, empathy, respect, ask, don't assume, don't, just again, have the patient feel heard, and then make your assessment as to what is going on here, and what can be provided, and I think, to the extent that this issue is coming up more and more, as I imagine it is, because it is being written about in the literature. In fact, this was a big topic at AAP this year in the workshops, is this issue coming up more and more, is to have some discussion, in your clinic, in your department, in your medical school, and are there institutional policies and procedures that would help guide every clinician here, every student, in terms of how to deal with these sorts of issues in a way that is respectful, and helps to minimize the anger, upset, countertransference feelings of the clinicians. I think that might be very helpful.
Yeah, and to add to that, I think, too, especially if it's happening in front of other providers, to also carry that empathy for the providers if they are on the receiving end of something that's harmful or aggressive, too. So, yeah.
Right. Okay.
But my actual question is going back to sort of the DSM is kind of founded in this tradition of like meeting criteria, sort of symptoms-based, behavior-based, and less of that etiological consideration. And so when we're trying to weave in and be sensitive to biases and cultural considerations, I'm just curious how, if you can share an example for navigating a decision tree, for example, around like oppositional defiant disorder in, a Black teenager, where they might meet that criteria, but if you step back and you take more of a trauma-informed lens or consideration of their school or environment where they might be on the receiving end of biases, prejudice, or other barriers to care. How do you kind of navigate this training where we've been instructed to kind of go down and say, yep, meets criteria, versus holding this individual and space for the systems approach that they're growing up in?
Okay, so the question was like oppositional defiant disorder. How do we think about the patient who meets criteria, but also bring in trauma-informed assessment and also understanding the social-cultural environment that the person is in? And you see, just by asking that question, you're halfway there. Okay? Really, okay? In the sense that you're not doing the symptom checklist and that's the diagnosis and that's the treatment. You're not simply doing that, but that's certainly our primary focus, in our work. But you're adding on that cultural lens. You see, you're adding on that cultural lens, and then this brings up the question: how much of what the person is experiencing may be related to the social determinants of mental health, even though there may be a biological basis to the oppositional defiant disorder, there may be other determinants here. So, we have medications or perhaps for that aspect, but then we need to think about the social determinants of mental health and look at the V codes and then look at how we're going to address these aspects of the person's distress, because these are determinants, and if we don't address them, that's not going to be part of the holistic treatment plan. See, so asking the question is halfway there. Yeah.
Thank you, Dr. Liu, for coming here. I'm Afshan Anjum. I think we have communicated a little bit as we extended that invitation for you to come here. I'm so glad you could come here. That was a very, very nice presentation. I think DSM-4, including the cultural formulation, and again, doing some more legwork there and expanding that is nice. I know as an institution, we have a lot of work to do. As a department, we have a lot of work to do with our trainees. It's good that we have the backing of ACGME on that. I want to ask you a different question. How about training the trainer? I know Dr. Vinogrado has, in a big way, started pushed for us to start this to create a culturally diverse environment, to be aware of that environment, to be inclusive and all of that. But for the professional development of our colleagues, so we sustain each other. Because diverse patients, diverse trainees also calls for different approaches from our side to be supporting our trainees, nurturing them, sustaining them. And do you have any resources for that? What are the rest of the institutions doing to support the ACGME requirements, how we go about training, but also understanding our own biases and developing?
Yes. How about the trainers? And I see this as I go around the country presenting this material, is that the whole issue of faculty development in this area is an ongoing issue that many departments are struggling with. This is not just here. It's really par for the course, because the faculty, tend to be older and not so trained in these areas, and so there's a real there's a lot of work that can be done. And I just mentioned here, the cultural elements of the relationship between the patient and the clinician also is very relevant to the cultural elements of the relationship between the residents and the supervisors. And just imagine the cultural identity differences there that can impact on the relationship and how that can impact on supervision. And there's a book that just came out on psychiatric supervision from Appy Press, where they do have a few chapters on this topic. Yeah. And it's an ongoing process. I think implicit bias training has gotten a lot of groundswell. I see more and more workshops being done in that area, and I think that that one is a start. But it's so critically important that the supervisors themselves understand what their cultural identities are, and how it impacts, their relationship with their supervisees. It has to start there as just the beginning. Yes, I think, yes, you're speaking about the diversity of the faculty and how do they relate to each other, and that's an ongoing task of how to create an inclusive environment. Yeah, I'll be speaking with the Diversity and Inclusion Committee after this grand rounds, where I'll be talking with them. And I've made a handout that I'll be sending to Dr. Vinogradov on this sort of topic. So feel free to share that handout on this. Yeah.
My question has to do with an issue beyond DSM-5 and our own consultation rooms. This morning, the New York Times reported on cultural diversity as related to who gets admitted to Harvard University, what student groups are privileged and which are not, and how is diversity handled in a rather well-publicized court case. Would you comment on this in your your own thoughts about making decisions at this level of our society.
Yes, well, as I understand it, Harvard has its own admission policies which do take a race and ethnicity into consideration as part of the holistic review of applicants, and consistent with the 2005 Supreme Court ruling of Bollinger. I don't remember the case now, but it's a landmark case, strict scrutiny is what's the term of any policies that include race and ethnicity as just one of the factors, and so Harvard was successful in the lawsuit that was brought by a group of Asian Americans, and I would say a fringe group of Asian Americans because many Asian American groups actually opposed the lawsuit. But they claimed that any attention to race and ethnicity is a problem and should be stricken. They felt that Asian Americans were discriminated against because, you're bringing in these other students that are not Asian American that maybe had lower test scores and things like that. Now, this flies in the face of the fact that even though Asian Americans are about 4.5% of the U.S. population, 22% of Harvard students are Asian American. Okay, so the same law firm that pressed this case also pressed the case involving Texas, where they had also race as one of the factors, and there was the Fisher case that was went to the Supreme Court and eventually sided with Texas, basically, in maintaining that. So to answer your question more directly, I would agree that race and ethnicity should be one of the factors for diversity. And I think, I hope that Supreme Court ruling of 2005 is maintained. Now, when this Harvard case eventually gets to the Supreme Court, I have great fear, given the 5-4 conservative majority, that 2005 ruling will be overturned. And then we'll come to the case where already about 5 states in the U.S. have taken this course of action, California being the first in 1996, and it did document a drop-off in, certain underrepresented groups, and I think to the detriment of higher education.
All right, well, on this sobering note, we'll stop here, and let's thank Dr. Liu again for a very important topic.
Thank you very much. Thank you very much. Yeah. Danielle?
You have been disconnected from the meeting.